Vascular surgery was transformed in 1947 when Portuguese surgeon Dr. Cid dos Santos removed a thrombosatheroma to restore blood flow, which became known as thromboendarterectomy, beginning the era of direct surgery. Dr. Edwin Wiley was the first American surgeon to use thromboendarterectomy to open stenotic arteries. Dr. Ron Stoney recalled the relationship between Drs. Wiley and dos Santos.
Cid dos Santos was one of his great all-time friends.
Yep.
And would you comment about what effect you think Dr. dos Santos had on Dr. Wiley?
Well, I think dos Santos certainly was the first surgeon that we know of that ever was able to actually remove the plaque of a blood vessel. We now call that endoarterectomy, or removal of the lesion, and restore circulation. And that led Portugal, 1947, and that led to the development of that as an option for treating people with obstructive vascular disease. And Wiley then it went to France, and Lariche there in France was doing it. They started to do, instead of the extremities, they started to do the aorta, and Jack Wiley, of course, popularized that and introduced that in America with his first aortoiliac endarterectomy, removing the disease, 1951. And that sort of set him on a pathway. And the last thing I'd say about dos Santos is, in 1974, he visited our hospital and our vascular service, and we had a great dinner with him that Jack Wiley and his wife Clea put on at their home in Belvedere Island. And at the meeting, I started to talk to Dr. dos Santos about how would it be if he were to come to the vascular meetings next year, and we'd have a sort of a dinner meeting and maybe recognize Jack Wiley. He said, I'll do it. So he came, and he was terrific, and he gave this remarkable address to Jack called Homage to Wiley, and delivered it at this restaurant, this lovely Anthony's Pier 4, a restaurant down in the waterfront there in Boston, and we all had a great time, and that was the beginning of the Wiley dinner and eventually the Wiley Society. But I think dos Santos had a great impact on Jack, and also they had more times together than I'm recording for you, but excellent people.
Could you tell us a little bit about the 1949 case in which you used the muscle flap or the muscle patch when you were a resident at Hopkins? This is a case that has intrigued me when I read about it. What was this about?
I'll try to be brief about the details, but this was a patient who had an osteochondroma of his manubrium, and Dr. Grant Ward, who was a surgeon there, conceived the idea of replacing the manubrium with a Vitalium prosthesis. And over the space of about 3 months, this Vitalium prosthesis eroded into the ascending aorta. So on a Saturday afternoon, sure enough, the thing burst, and we took the patient to the operating room and opened his sternum. Dr. Ward was a partially incapacitated individual. He had a syringomyelia operation and had one arm up in a permanent cast here. And I remember when we opened the sternum and this blood shot up to the operating room light, Dr. Ward took his other hand and put his finger on the hole in the ascending aorta. And I was his resident at the time. He said, Denton, what are you going to do now for me? I said, well, Dr. Ward, we'd cut your finger off and leave it in there, if you can spare that. And I said, well, why don't I just take a little piece of the pectoralis muscle and make a patch and patch the hole in the aorta. And so I cut a piece of pectoralis muscle and slipped it in by suturing part of it around there. And I said, now pull your finger out. He pulled his finger out, and I pulled the sutures down and patched the ascending aorta. And I think that was one of the first operations of this kind.
What brought you to think about using a muscle flap? Just spur of the moment, or?
Well, I guess it's spur of the moment, I've forgotten just what. What would you take? Would you take a piece of skin or something?
With the outbreak of the Korean War in 1950, rapid transport of the wounded via helicopter to MASH units opened the possibility of arterial repair. Doctors Frank Spencer and Lieutenant Colonel Carl Hughes were very active in promoting use of the technique at the edge of the theater of war. In an interview with Dr. Roger Gregory, Dr. Frank Spencer discussed his direct participation in this advance, aided by such tools as the Potts clamp.
When you got to Korea, though, what you ran into was a little startling.
Yeah, they say I didn't arrive in Korea with any enthusiasm. So be it, I'll survive. So you arrive in this dreadful-looking country, and you wonder what in the devil are we doing here. It was a freak of circumstance because of the negotiations. They had this no-fire zone, and for 6-mile circle. The big advantage of this that made them feasible was that put an operating area closer to combat than had ever existed in history. What was not known at the time was that if you can't fix an artery within 6 or 8 hours, you better amputate because the leg muscle is dead. And so that when moving them up close to the lines provided surgical facilities. There were 2 Quonset huts. An additional thing that had come in were helicopters. And the helicopter pilots were fabulous. Right in the middle of the night, they were combat, they'd go up in their helicopter without lights, flying low on the ground and pick up a wounded man and bring him in. I think the evacuation time could be 30 minutes. And it was an interesting environment because it was essentially structured to resuscitate wounded men, give blood, get out of shock, stop the bleeding, and then send them back to a base hospital. But as they'd been talking for a year, they gradually moved, had a little operating room. I was going to be chief of surgery in this little tent.
In the Quonset hut.
One of the first patients they showed me was an 18-year-old with a dead foot. Had a little wound of his superficial femoral. And that was all. I said, that was 3 days before, so it had to be amputated. I said, why didn't you fix it? Contrary to orders. What do you mean, orders? I never heard this before. They opened up the rule book, 100 pages, like a traffic direction, and it said very clearly, all arterial engines will be ligated. I looked at this, and it was a major decision. And I guess it's the Hippocratic Oath, what to do best for the patient, not for you. There was 4 or 5 other people who wanted to participate. I had to teach them how to sew an artery, because I knew how. That was the only one that knew how. I said, this is a great experiment. If it succeeds, we get a decoration. If it doesn't, we get court-martial. Said, does anyone want not to participate? And to a man, all 5 of them said, let's go.
Now tell me a little bit about the vascular clamps that you had at that time.
Well, there were no clamps. We had 2 bulldog clamps, or maybe 4. But in the interning at Hopkins with a blue baby operation, and the Potts clamp didn't appear until about 49. And in doing the blue baby operations, you would tie a bulldog clamp on the subclavian and tie the end of it with a ligature so it wouldn't slide off, and then you could pull on it. And so that was what we proceeded to use with arteries. We put on our bulldog clamps and tied on them, we could pull them together. That's all we had all the time I was there, because I kept applying for Potts clamps, which I knew familiar with, no answer. Nothing.
But you finally did get some Potts clamps.
And it was a strange thing. It was because this Army Jeep pulled up, and this nice man, Carl Hughes, got out, was a colonel, and he looked at what we were doing and sort of shook his head in dismay. And without any comment, he went over to his Jeep, got out of the compartment, he took 2 Potts clamps and gave to me. I couldn't believe it.
Manna from heaven.
In 1951, a new vascular surgical society was formed. the International Society for Cardiovascular Surgery, or ISCVS. In 2001, the society changed its name to the American Association for Vascular Surgery.
When I was the president of the ISCVS, the American Association of Vascular Surgery, we tried to define what a vascular surgeon was. And
Right.
There was 5 pillars.
Right.
There was the non-invasive, the vascular medicine, the vascular surgery, the endo, and the critical care.
The joint council of the two societies discovered it needed professional management. Mr. William Maloney of the Professional Relations and Research Institute was hired to perform various business functions for both societies.
It was obvious to me and to us that the program was becoming more and more vascular, that the attendance was the cardiac attendance was dropping significantly, and it's sort of like the American Surgical, where they say there's no nobody in cardiac goes to the American Surgical anymore because they don't do any of those papers. I don't know whether they do that for vascular or not, whether you do many vasculars at American Surgical, but two, yeah. And so, yeah, it might have been worthwhile to have done it sooner. I think that the way you did it, and the involvement of Becky Marin, the departure from our organization, which I think was a very definite plus for the two societies, to have your own full-time staff, people you owned, was the right way to go. You come to a point where our model wasn't good for you.
The decade of the 1950s was a breakthrough period for vascular surgery. 3 signature operations: carotid endarterectomy, aortic graft, and femoral bypass started the growth of reconstructed surgery. Catheter arteriograms provided a roadmap for planning operative procedures. The Dacron graft played a central role in revascularization of various vascular beds. In 1955, there was a touch of endovascular surgery by Drs. Wiley Barker and Jack Cannon.
You did a number of procedures and wrote a lot with Jack Cannon, whom you mentioned earlier. One of the devices that is still occasionally used today is an endoarterial stripper that's used for removing plaque in the femoral and iliac artery with the semi-closed technique. Tell us a little bit about how you thought of developing that and whether you saw that as the beginning of the endovascular era.
After a day doing an open endarterectomy in the femoral artery, this is a long, tedious operation. The first ones I did the entire femoral artery open, and that becomes a tedious repair. And Jack and I were sitting in the office talking about this and figured there ought to be some better way to do this. And he wanted to make an instrument that you could pass, and I wanted to make an instrument that would plow ahead, so to speak. It wasn't a very good idea. Jack's was much better. We designed loops. I went home and bought some piano wire, heated and distempered, if you will, about 3 inches of the end, made a loop out of it that was a loop that sort of leaned forward. I flattened that leading edge a little bit, so it was not quite cutting, but it was a little less than blunt. And I used those all my career until Jimmy Yao borrowed them for a display. They disappeared from the display and never been heard from since.
Reconstructive innovations continued into the 1960s with Dr. William Blaisdell's extra anatomical bypass in 1963, leading all the way to Dr. Stanley Crawford's surgical technique for thoraco-abdominal aneurysm in 1978. Dr. Charles Robb reflects on this growth of the specialty after World War II in an interview with Dr. Norman Rich.
Well, there's only been, even today, 2 truly original ideas into arterial surgery. The other ideas have come from other branches of surgery. And the 2 basic original ideas, which changed surgery to quite a bit, were the introduction by Tom Fogarty of the Fogarty catheter. That, as we all know, is a balloon which was passed through the thrombus or embolus, usually an embolus, and then inflated and withdrawn, hopefully with the embolus.
I think one of the amputations that one day, Dr. Cranley, he says, you know, this is happening all the time. I said, it's obvious. He says, let's fix it. So I thought about it, and I made the balloon catheter. That was one time when a light bulb went off. That doesn't happen often.
You were fiddling around in the attic with ties and taking the end of a glove off?
Yes.
Is this how it all started?
Yeah, it was very simple. I stole a ureteral catheter.
Yeah.
And I took a number 5 glove, and I cut the fingertip of the baby finger, and tied it onto a ureteral catheter that was used.
And that was a major advance, but an even bigger one was the introduction by Arthur Voorhees of Columbia Presbyterian Hospital of plastic porous cloth, which was not a complete tube, but formed a tube made of the plastic mesh and the blood clots in the small holes.
It was while Art was senior resident at Presbyterian that Dr. Blake Moore was operating on a patient with a ruptured abdominal aortic aneurysm. And when Dr. Blake Moore asked for a homograph to place in the patient, there was none available. So Art left the operating room and sewed an appropriate size tube of Vignon in, and they placed that in the patient, which was the first synthetic graft treatment for an aortic aneurysm at that time. The patient expired of exsanguination, but at autopsy the graft seemed to be functional. And encouraged by that, several weeks later, they did a second patient who recovered, and that was the first successful operation using Vignon or any synthetic. That was reported along with 17 other aneurysm operations, most of them aortic aneurysm. I think there was one popliteal aneurysm in that group. And it was amazing that of that group of 18 patients, there was a 56% survival. And that was in a period when aortic surgery was exhausting and challenging for anyone. So survival rate of that level, of course, was quite impressive.
And this was a huge advance. I believe it changed vascular surgery more than almost anything else. And this made arterial surgery, particularly of the large and medium-sized vessels, was now possible.
Dr. Wesley Moore describes the case during which the first extra-anatomical bypass was conceived by Dr. William Blaisdell.
I happened to be a second-year resident at the time that the axillofemoral graft was innovated. In the VA system at that time, the residents had a lot of independence. Right. The attendings would come in the room when you had a problem. And so the chief resident and I were doing an open aneurysm repair on a patient who had an AK amputation on one side. And in those days, every aneurysm repair was done with a bifurcated graft. So we had everything exposed. We had done the proximal anastomosis. We did the distal anastomosis on the good side. And then we took the limb to go to the side where he had the AK amputation. and discovered there was no iliac artery. So what did we do with this extra limb? Well, we clamped it, tied it off, oversewed it, and everything went fine. The day after that operation, that graft thrombosed. And that patient was ischemic from the umbilicus on down.
Wow.
So we whipped him back up to the operating room to redo whatever we had to do. And with the induction of anesthesia, he had a cardiac arrest. And this was 1962. And closed chest resuscitation had just been introduced. So we were pushing on his chest, and he was intubated, so we were able to ventilate him. We got his heart started. So now we have a patient who just had a cardiac arrest. He's now resuscitated, who is ischemic from the umbilicus on down. And, you know, what are we going to do? Reopen his abdomen? So Dr. Blaisdell came into the operating room, went back to his office, which was a couple of rooms down, scratched his head for a while, and came back with the concept of the extra-anatomic bypass. Wow. And so under local anesthesia with the patient intubated, we cut down on the axillary artery. Under local anesthesia, we cut down on the femoral artery. We didn't have any tunneling devices, so the only thing we had was an external vein stripper. And so we created a subcutaneous tunnel over the rib cage, and thunk, thunk, thunk over each rib, got a tunnel and pulled a graft from the axillary artery down the femoral artery and connected it. That worked. That patient lived for another 5 years.
I'm very interested in your article on the bypass to the isolated popliteal artery. How you come up with that?
Well, we had started early on back in 1961 doing some tibial vessel vein grafts. They, as a group, didn't do as well as femoral popliteal bypasses as far as long-term patency were concerned. We got an awful lot better when we used loops, and at least in our department, used in situ vein grafting, which I think is, if done the way the Albany group did it, probably gets less damage to the vein, and that it's got nothing in it but heparinized blood, which I think veins like a lot better than all the other stuff we've put in them over the years. So I think that tibial vessel grafts became very much more feasible, shall we say. But in that time, it seemed as if maybe since you could see a popliteal artery on an arteriogram filling and emptying, maybe the idea would be to raise the head of pressure in the popliteal so that you might very well get some increase in collateral flow distally. So we started doing a few of those, and indeed we saved some feet, and we began to publicize it a little bit, and we put some flow meters on those grafts, and they had respectable flows in them. Some of it probably went back up the leg, but some of it clearly went down the leg. So we did save some feet, rather spectacular salvages with them.
You may have done the first anterior tibial bypass with a vein.
I think also the first perineal, if you want to know for sure.
How did you decide to go ahead with that?
Because that was all that was left.
The use of the Dacron graft fueled the era of direct reconstructive surgery. Dr. Ben Eisenman tells Dr. Norman Rich the story of how he accidentally developed the idea of the Gore-Tex graft.
Or Bill Gore is who subsequently named the product he made, Gore-Tex, was also a skier. And he and his wife and my wife Mary and I rented a cabin together in Vail one spring. And after skiing one afternoon, we went down for drinks, and Bill Gore had a gray tie on like that, and he said, "Feel this," and I felt it was very silky, a very sexy feeling thing. And I said, "What is this thing?" And he said, "Look, He took his tie out like that, and he poured some mustard on it, like this. And we hadn't had a lot of drinks, and he said, now watch, and he washed it off. And I said, gee, what is that stuff, Bill? And he said, well, we call it Gore-Tex. He said, I knew Bill had worked in Cleveland and had a patent, he said, on this expanded Teflon. And he said, it's an expanded Teflon, and we use it. He said, look, and he took out a piece of cloth out of his pocket like this. He said, you hold up one side of it like this and on this side, and he lit a match, and he could blow the match out through the cloth. And then he took the cloth and he cupped it like this, and he poured water in it, and it held water, and he dumped it out. And I said, well, Bill, that's an interesting material, that Gore-Tex. And I said, could you make it into a tube? He said, yes, we make tubes anyway of this for these new businesses called computers, little tiny tubes. We could make them bigger. I said, could you make them big enough to be used as a prosthetic in states to replace arteries or veins? He said, sure, we make it down at Flagstaff, Arizona, and I'll just tell our guy down there to make it your size. So by that time I was in Denver, and we had the laboratories at the university and the animals. And so he made it in sizes. At first, the pore size was so big that the blood went through it. And then it was so small that the oxygen didn't come through, and so he altered the pore size. And we then, with the fantastic group of young guys I had working with me at the time, we tried it in all sorts of animals and all sorts of arteries and veins, and we decided we could use it to substitute for veins.
Doctors Jock Wheeler and Roger Gregory recount their participation in the first femoral popliteal bypass graft used in the U.S. in 1972.
Back in the 1970s, PTFE was beginning to be developed as a bypass material, and you actually were involved with implanting probably the first femoral popliteal bypass. And Roger Gregory is with us today so that you can talk about that historical experience.
Well, I'd been in town with Jock for about less than a year, actually, after I'd finished my fellowship, and we had a patient that came into the office with a critical ischemia of the leg, an elderly diabetic lady with rest pain. And the problem was she already had her saphenous veins removed for varicose veins. So we brought her in the hospital and angiogrammed her, and she did have what looked like a reasonable popliteal segment below the knee. Well, a few months before that, we'd used a PTFE graft by another manufacturer, and we did, I think, a tibial bypass. And post-op, the graft thrombosed, and we went to do a thrombectomy, took her back to the operating room, and the graft split from top to bottom.
You were using a Fogarty-type catheter,
Right.
balloon catheter.
Put a balloon catheter in. When we drew it back, the graft split. So we were not very excited about using another PTFE graft. We felt like we couldn't use a Dacron graft. We'd use that in my fellowship, and primarily in the AK position. Certainly below the knee was not a very good situation. So we were in a real dilemma as to what to do with this patient. We heard rumors that there was another company, the Gore company, making a PTFE graft. So I don't know whether I should say this on camera, but as Jock used to say, I would call Jesus if I could just get his phone number. So I got the phone number for the Gore company and called up, and a guy named Jack Hoover answered. And we talked about the problem we had, and he said, oh, fine, we've got a graft that I think you can use. It's FDA approved, and when you need it. But then I said, but now wait a minute, we're worried about burst strength, and they called it hoop strength. And he said they'd solved that problem, the Gore company, by using an external film or coating on the graft. So I went back to, when do we need it? And I said, well, right now. And he said, well, how about tomorrow morning? And he flew all night and brought us the graft.
He was in Flagstaff, Arizona.
He was in Flagstaff, Arizona. And when we looked at the graft, we felt like it was a little stiffer than we wanted, but it wasn't saphenous vein, but it looked very reasonable. So we said, okay, fine. Next couple of days, he had us 6 of them to use. August the 25th, 1975, we took this patient to the OR, and we did a femoral to below-knee popliteal bypass. Patient did well, and we thought it was just not that unusual. We had a difficult problem was solved, we went on to the next patient. Later, I found out from Jack Hoover that this was the first graft they had sold, and subsequently they have sold 5 million of these grafts.
Mm-hmm. Was it a 6 millimeter graft?
6 millimeter graft.
Oh yeah.
I remember we used a 5-O-proline on an RB1 needle for the distal anastomosis, and when we opened the clamps, it was like a watering pot came out. Well, we were just almost panicked. We didn't know whether it would stop or not, although we had a similar problem with the other graft that we'd used. And we reversed the heparin quickly and put on some hemostatic agents, and finally with a little patience it stopped. And we learned after that that was more or less routine. But this was a very exciting time for us, certainly for me. I'd never heard of PTFE when I was during the fellowship.
Was Jock there with you when you for that first case?
Absolutely. I wasn't that busy the first year. It kind of got out of hand after that, but the first year I used to scrub with Jock all the time, and vice versa. He would keep me out of trouble, and I had a lot of experience being an assistant in Houston, so we scrubbed together all the time.
In the 1970s, surgeons began exploring the development of non-invasive diagnostic tests, including the plethysmograph, the pulse volume recorder, Doppler ultrasound, and the duplex scan. These tests were developed solely by vascular surgeons who established fee-for-service vascular laboratories in many U.S. hospitals. Dr. Eugene Strandness was the first to use Doppler ultrasound to detect flow velocity in arteries and veins. The book Hemodynamics for Surgeons is a must-read for vascular surgeons. Finally, Dr. James Yao used measurement of ankle systolic pressure in the ABI for objective study of patients with arterial occlusive disease.
In 1960s, I can't remember what year, Loren Park, or the Park Electronic Company, come around in London to demonstrate his Doppler.
Yes.
And I saw the instrument and I get interest in it. And you don't feel the pulse, but you still can hear the signal. So with that, you can measure the pressure of the leg. I was interested in measuring blood pressure in the leg, but it's kind of clumsy to use plethysmograph.
Yes.
And I thought using the ultrasound would be easy, so I started working on it. We compare the ultrasound technique with plethysmograph, with intra-arterial pressure. We have a pretty good system going to collect all the data.
While the Doppler was being applied to vascular surgery by Strandness and Sumner, your research allowed the ankle-arm index ratio to be demonstrated, and I have to say that this simple test revolutionized non-invasive testing. And I think this is well recognized. There were many other people involved in non-invasive testing, but not with a simple test that provided so much information. When did Trevor Windsor fit into all of this?
Well, Trevor Windsor wrote a book, I don't know if you know that, on non-invasive, non-plethysmograph. Most of them are on the limb blood flow. He did mention about pressure index. He did mention about the lower limb pressure compared with the upper arm. and wrote about that, but really never applied clinically.
Right.
We did a lot of tests on patients with severe ischemia, complication, and normal. So we kind of know with a different level angle pressure index reflect the clinical symptom. And this is a simple test. It can be done by anybody.
Right.
So I'm think, we need a simple test can be done by everybody instead of having too complicated tests.
One of the most important missions of the Society in the 1970s was improving care for patients with vascular disease. Two reports, one by Dr. Jack Wiley and one by Dr. James DeWeese, called for vascular specialty training via a one-year fellowship and for specialty board certification. Over the next decade, all presidents of SVS engaged in negotiations with the ABS, the RRC, the ABMS, and the ACGME. Dr. Ron Stoney remembers the presidential address by Dr. Jack Wiley.
It all stemmed from the idea of, what kind of health care could you deliver and what did a patient deserve as far as health care, particularly in the vascular arena. And the experience that he had, sort of the same that Dr. Bell had in general surgery, with these people going out without really being accomplished enough to handle some of the problems, led to the idea of a more expanded exposure. During the residency, we did at first have more assistant residency exposure rather than just maybe 1 month and then as chief resident. So that was one difference. But I think eventually he just was talked more and more about, we really need to make a change here, and we need to help develop. He was talking about like he was doing it, like we could develop. And I don't think we was necessarily Bill Ehrenfeld and I. We were he had a great camaraderie with many, many leading surgeons around the country. And it all sort of came to a head. The paper was delivered, Vascular Surgery, A Quest for Excellence. And in 10 years, he and a great group of active people put together I guess you'd say a package that the American board accepted, and we had our certificate of competence in vascular surgery 10 years after he gave his paper.
Did he have an opinion about a separate board for vascular surgery or defining it separately from general surgery?
At this point, I believe Jack wanted to make sure that surgeons were trained in vascular surgery. And he felt that a fellowship was the best way to distribute vascular surgeons in other training programs. I don't know that he felt strongly about a separate board, but he understood that there was a specialty of vascular surgery.
Dr. Jim DeWeese chaired the Committee on Vascular Surgery with Drs. William Blaisdell and John Foster as members, which evaluated care in America's hospitals during the Johnson administration.
President Johnson had established an interest in a battle against cancer, heart disease, and stroke. And the program ended up, what they finally did was establish some committees from all specialties. And these committees were to look at the optimal needs or optimal resources needed for the improvement and performance of excellent procedures, operations, and treatment. We decided, and after writing a paper, sent it around to 50 other people interested in doing vascular surgery, and finally felt very strongly that the way to improve vascular surgery was to get people doing vascular surgery who had been trained in it and preferably certified.
An inter-society report by the American Heart Association and the SVS provided recommendations on standards for non-invasive instrumentation in peripheral vascular testing. In 1973, Dr. Laser Greenfield designed a filter that would allow the extraction of clots without impeding flow.
I thought that it ought to be possible to extract clots from the pulmonary circulation, and got the idea of putting a cup device on the end of a catheter. I'd had a lot of catheter experience at the NIH, and I was very comfortable putting catheters into the pulmonary artery. So I was able to work with a petroleum engineer who fashioned a cup that could be attached, screwed onto the end of a catheter, and began to pull clots out of patients. And actually we saved a series of 10 patients that we subsequently reported, but many of them had recurrent pulmonary emboli even after we extracted the clots and got them out of shock. So in further discussions with this petroleum engineer, he said, you know, this whole business of moving clots in the circulation is a lot like the problem we have with sludge in the pipelines. The sludge gets stuck in the valves and we have to dig them up, and it's just a big mess. And he said what we do is to use a cone-shaped trap, because the geometry of the cone allows you to fill it up to 70% of its depth, and yet flow continues around it. So with that fundamental concept, we sat down together and designed a device that could serve biologically to trap clots in the circulation. Those devices were initially put together in the garage of one of his workers, and we began putting them in dogs, and 2 years later we were able to put them in patients. But in terms of the sequence of management, I've always thought that the catheter embolectomy was really the best idea I ever had. The filter just happened to come along with it. But the filter, of course, has had the lasting success for the past 40 years. So I think it is a testimony to the value of collaboration with people, not necessarily in your own discipline, but people who just have ways of solving problems that you may not be familiar with.
With the notion of collecting information from the many surgical procedures performed on the edge of combat during wartime, Dr. Norman Rich compiled the Vietnam Vascular Registry.
Tell us more about the registry, the mechanics of
Well,
how...
you know, Carl Hughes had a piece of cardboard that I saw as an intern and tripler, and he had the names of his Korean War patients that he had treated, and I was always kind of intrigued with that. And then when I saw his piece of cardboard at Letterman when I was in my residency, it even piqued my interest more. So I did talk to him about trying to document the Vietnam vascular injuries in Vietnam. And the good news was that I had a lot of support from many people. Something like this is never done alone, as we know, and I was merely a scribe for about 600 young American surgeons who served in an 8-year period in Vietnam. But even though we were Army and we were focused on Army, one little anecdote I would throw in, when I had my first exhibit at the American College of Surgeons in 1967, the Navy Surgeon General R.B. Brown came by, and his question to me was, Major, what do you have against the Navy? And I said, sir, you know, nothing, sir. And he said, well, why aren't you including the Navy wounded and the Marine wounded in your registry? And I said, well, I didn't have permission. His comment was, well, you now have permission. It was like a Marine Corps general said to me at that time. He said, make something good out of this horrible mess, and the Vietnam Vascular Registry is your chance. This is the first time that there's been a transfer of knowledge from the civilian community that's being looked at on the battlefield, and that's related to our specialty area of interest, and that specifically is endovascular surgery.
In 1978, Andreas Grutenzig of Zurich, Switzerland, developed a balloon catheter capable of dilating arterial stenosis. He presented 5 cases of percutaneous transluminal coronary angioplasty in a letter to the editor of Lancet in February 1978. This was the beginning of the PTLA in treatment of arterial stenosis. Dr. Julio Palmaz, inspired by a talk by Grunzig in 1978, developed the balloon expandable stent. patented in 1985, which greatly aided in reducing post-operative restenosis. The 1980s saw many developments in vascular surgery, beginning with the establishment in 1982 of the Certificate of Special Qualifications in General Vascular Surgery after 12 years of negotiations with the American Board of Surgery. The first certificate was Dr. Jack Wiley's reward for his leadership in the pursuit of recognition of vascular surgery as a surgical specialty. After certification was achieved, the rapid growth of the specialty can be seen in the number of regional societies that came into being across the U.S. and Canada. The establishment of the Journal of Vascular Surgery followed in 1984, with Dr. DeBakey as editor-in-chief and Drs. Jesse Thompson and Emmerich Zalagi as senior editors. Dr. Zalagi, who performed the first aortic aneurysm repair on live television in 1957, was widely considered the conscience of vascular surgery.
And that describes what I have done. That means that I reported things truly, and also criticized other people who did not report it correctly, and directed them into the right direction.
This candor was demonstrated in a remembrance by Dr. Larry Robson, a former fellow under Dr. Zalagi.
I was attending a meeting at the University of Minnesota in Minneapolis, and there was a panel up there of prominent vascular surgeons, including Dr. Zalagi and Michael DeBakey. The panel was being moderated by Richard Barco, and they were discussing the treatment of intermittent claudication, and particularly lumbar sympathectomy. And Dr. Barco asked Dr. DeBakey, do you do lumbar sympathectomy for intermittent claudication? And we all know how DeBakey went, oh yeah, we do that sometimes. Dr. Zalagi, do you do lumbar sympathectomy for intermittent claudication? I can't mimic his accent, but he said, doing lumbar sympathectomy for intermittent claudication is malpractice.
The other senior editor, Dr. Jesse Thompson, was a Rhodes Scholar and a surgeon known for his contributions in carotid surgery. Dr. John Town, a former fellow of Dr. Thompson, remembers his mentor.
Dr. Thompson's really well known for carotid surgery, obviously. And what was his style of doing it? Did he shunt everyone?
He shunted everybody.
And what kind of shunts did he use? And tell us something about the detail of those from your memory as a fellow.
The first, I think Dr. Thompson had the most incredible judgment of any surgeon I've ever worked with. And there was a saying in the hospital, in Baylor Hospital where he worked, if you want an operation, ask so-and-so. But if you really want to know what should be done, you ask Dr. Thompson. He was a very meticulous surgeon. I mean, he clamped and tied, and he was a slow surgeon. He always had control. And it was amazing how he had control. I can tell you in the year I was there was not a stroke. We never took one of Dr. Thompson's patients back to the OR. And I never saw a graft infection.
Dr. John Oshner also played an important role in the founding of the JVS.
John Oshner is a leader and an idea man. From your vast experience of being president of 10 different surgical societies, plus boards, committees, and so forth, you had quite a substantial experience in this area. Somewhere in there, you came up with the idea for the Journal of Vascular Surgery. Is that true, or can you expand on that?
No, I didn't come up with the idea. Dr. DeBakey did. In fact, he even had a publisher called Masson, French, M-A-S-S-O-N, I think it was. But he brought it up, and the two societies, joint societies, met together at the time, and they decided that, yes, we ought to have a journal. So they developed an ad hoc committee. We discussed who we were going to get as a publisher, and the firms that we were considering were Mosby and University Park Press. And I felt that Mosby was definitely the way to go, only because at that time I was also secretary of the Thoracic Society, of the American Association of Thoracic Surgery. And we had a journal that was the most read journal in the world, mainly because we had all the Europeans reading it and Asians too. But it supported the whole society. I mean, it made us money. So I know if we went with them, they could do the same thing with the Vascular Society. And that was the biggest fear of going with anybody else, whether we could afford it.
One of the things that I'd been told many times about you in particular was that you were always modest, that things that you really did, you would give other people credit. And I think this is a prime example. You were able to deliver this into reality, from an idea and bring it into reality. Yeah. And I think this is a prime example of your modesty.
I was trying to save us money too, because there was certain people that wanted to pay everybody something, and I had a hard time with that. One person in particular never would get over that he wasn't known as the first editor, and that was Shalagi, and I felt sorry for him, because he really did a lot of the work for Dr. DeBakey when we made Dr. DeBakey editor and Shalagi an associate editor. But DeBakey even sent me a letter and had, God, he must have had 40 guys to consider. But he wanted on the editorial board, he wanted to be editor. He wanted Stanley Crawford to be associate editor and George Morris to be associate editor. But I didn't think that was right. You couldn't have all coming from our group, you know, that were trained. But anyway, so we came up with a list and sent it back to the societies, and we let them pick.
You were editor of the Journal of Vascular Surgery. As you know, Fogarty paper, when he first submitted, was rejected by Annual Surgery, and finally picked it up by Loyal Davis or SGNO. Parodi's paper on endovascular surgery was rejected by Journal of Vascular Surgery, not from you guys, somebody else. I won't say it. Yeah. To me, this is two most significant invention in vascular surgery, and both of them were rejected. I just want to know from you, is there something wrong with the peer review system, or what happened? I mean, how could that happen? What can we do to avoid it? This is the big invention.
Well, Jimmy, I mean, I really recommend that everyone take a peek at Jim Watson's memoir of Avoid Boring People. You know, it relates to his thought process of sort of maverick thinking, renegade thinking. It resonates with me. One of my very good friends was chairman of medicine, Tachi Yamada, at our institution, became vice president of a major pharmaceutical company. Tachi just stepped down as the president of the Bill and Melinda Gates Foundation. And they give out small grants. And Tachi, when he was on our faculty, spent day and night rewriting and writing R01 grants. And I mean, I've been in the same place, academic award from NIH, R01 grants. The reality is that if you look at probably the 20 most major contributions to medical areas in the last 4 decades, none of them have been funded or have been outreaches of peer review at the NIH. And so the outcome of that was that Bill Gates said, if somebody's got an idea, we're not going to give $100,000 every year for 3 years or 5 years or something, but we'll give $100,000 as sort of hobby money, you know, in a derogatory, some people do that very derogatory. He didn't, to come up with ideas. They had materials they could spray in fields that insects would pick up, and then ultrasound, they were sensitized, the insects were sensitized to the ultrasound, harebrained idea, and nobody thought it would work, but it worked. And I think medicine's the same way. I mean, Juan Pradi's paper was accepted by Ramon Bruguera, and he and I, the only difference between our offices is a little thin wall. right now. And Juan's been a good friend. I was not part of that decision. I have no doubt there are good ideas that don't have p-values associated with them that are observational. I mean, the first AX-FEM on a patient had an MI on the table that was supposed to have an amputation. They couldn't do the amputation, so they did with local anesthesia. I mean, you know, that was game-changing. So, you know, I think you have to have very intelligent people, and you have to have the resources to make mistakes. And with, you know, I mean, we've got very major labs that are quite at risk with the funding for, you know, federal funding. So you have to think about what you can invest in, and you have to think a little bit smaller and take a little more risk at times. I don't think people should have papers accepted because they've got a great track record. The paper should be accepted because it generates new knowledge, not because they got credibility. Same thing happens with other granting agencies.
The journal is now 28 years old. Here's a list of members who served as editors up to the present.
Is the journal committed to only taking articles that fulfill a certain criteria? That is, that they have to have certain numbers, the statistician says it's valid, et cetera, et cetera. Or what would happen if I sent in, I've done this in 3 patients and I've never been reported before and I think it's great. What do you do with an article like that?
Case report.
Case report.
Case report. That would be a case report. Now we took, you mentioned statistician, we took, I think, checking statistics to a higher, different level. As you notice now, the vast majority, not the vast majority, but good number of the articles published in our journals and other journals are outcome paper based on large databases. National Inpatient Sample, NSQIP, VQI. In my mind, those papers are nothing but a statistical exercise. That's all what they are. Mm-hmm. So if the statistics are not there, you've got no paper. Mm-hmm. So for us to go out and publish papers in a journal on outcomes without really being very careful, the statistics are appropriate and the significance is really there. And the significance is meaningful, not only, I mean, if you take millions of patients, a 0.000001 may be statistically significant, but is that clinically pertinent? So you really need to look at all these issues. So what we decided to do is we beefed up our statistician role in the journal. So now what we do, almost all outcomes papers go to our statistician, who is really excellent. We have 2 or 3, they're all excellent. So they go to them. And that will be a 4th review. So the authors will get the 3 reviewers, who are vascular surgeons or vascular medicine people or radiologists, whatever we have in the reviewer pool. And then in addition to that, they will get statistical review. And that's a lot really to bite on, but this is the only way you end up publishing an outcome paper that's respectable. And the issue now that we're getting so many submissions, we could do that. I mean, if we're really struggling for publication, you know, sometimes you compromise. You shouldn't, but sometimes you compromise. But we're not, and we haven't been struggling for long, not us, not the editors before us. We're really, the Journal of Vascular Surgery is way beyond any one of us, so to speak. It really is. I mean, it's an institution now, the same as the SVS. I mean, everybody say, you know, when you were president of the SVS, I mean, what do you do? I always say the SVS is beyond any certain president or secretary or, I mean, it is now an institution. And we all have to protect it and move forward with it. But it is bigger than us. The journal is bigger than any one of us.
Starting in 2013, the Journal of Vascular Surgery partnered with the Venous Forum to create a new quarterly journal on venous and lymphatic disorders. With the growth of information technology, Dr. Norman Hertzer grasped the possibility and importance of accurately compiling surgical outcomes, which was the theme of his 1994 presidential address.
And it showed that volume made a difference at both the hospital and surgeon level. There was a lower mortality rate in high volume whichevers, for aortic aneurysm repair, and there was a lower amputation rate for high-volume surgeons and hospitals with respect to lower extremity bypass. And it only makes sense.
The research initiative's meeting started in 1988. We are the only surgical specialty to have joint meetings with the NHLBI NIH. The meeting was renamed the Joan and Julius Jacobson Research Initiative's meeting in recognition of their generous giving to the Lifeline Foundation.
Your role as a philanthropist, and I have to say that I'd never heard of anything like this from a surgeon. Endowing 3 chairs of vascular surgery.
Now it's 5 chairs.
As well as making a giant contribution to the Research Initiative Program for SVS, endowing several research fellowships and academic awards, working through the American College.
At present, the Research Initiatives meeting has been integrated into the American Heart Association Atherosclerosis, Thrombosis, and Vascular Biology meeting. In 1986, Dr. Alan Kellow established the Lifeline Foundation, which later became the American Vascular Association, now renamed the SVS Foundation, which is the engine of SVS's philanthropic efforts. The SVS Foundation works in partnership with the von Liebig Foundation, NHLBI, NIH, and the American College of Surgeons.
You're also an economist, it seems. You know something about finances, and you taught doctors who didn't know anything about 5013C type of thing. Would you comment on Lifeline a little bit, please?
The life of any society, and many, many other things, is in the young people who are in it. And young people have expenses just as old people do. And I always thought that the ordinary young person wants to do something more, whatever it is he or she is doing. And research is an easy avenue to do something more, if you can get funding. Now, the ideas aren't coming from people like me. They're coming from the 25, 30, 35-year-olds. And these are the people who are tomorrow's people, who are going to be making decisions, you know. And we should support them. And you can't support a research effort of any importance on a $5,000 grant, nor can you support it on a $50,000 one-year grant. And it's got to be continuing, because this young person is sacrificing an income stream if he were to go into clinical practice. And I just thought that with all the money that's flowing around, and we had a lot of cash in this country at one time, we better do something about it. That was the origin of that.
Yeah.
The foundation supports K08 and K23 grants by the NIH, the E.J. Wiley Traveling Fellowship, courtesy of W.L. Gore Associates, a Resident Research Prize, a Student Research Fellowship, Clinical Research Seed Grants, and Clinical Study Planning Grants. Dr. James Yao, John Manick, and Alex Clues reflect on their efforts to secure funding for various grants.
John, I just want you to know the most enjoyable time I have is working with you together in the Lifeline Foundation.
Well, me too, Jimmy.
And you have done a lot. The Liebig Foundation, tell us how that started with Liebig.
I was a retired president of the SVS, and ISCVS, I guess, was the last presidency I held, and they, I think, were casting about at the Joint Council meeting for something to give the retired presidents to do, so they gave me the job of heading the Lifeline Foundation, which had been, you know, under the aegis of other past presidents before me. The only thing they did when I got to be president is they took away the funding. They were giving the Lifeline $50,000 a year from the SVS, which they took away, and the ISCVS was going to give us 2 more years, if I recall correctly, and we didn't have any money. So Jimmy and I and Alec Clues, who was the secretary, I guess, at that time, or treasurer, or whatever he was. Treasurer. You were secretary, I guess, Jimmy. So we wondered what we were going to do, and one of the first things we thought we'd do is try to hit up some people we knew in the field who had some money, and we went to see Tom Fogarty and got a little money from him, which was a start. But then, we talked and talked, and Jimmy was the one, I think, who really originally came up with the idea, why don't we try to see what the NIH would do about partnering with us in research training. There was the K08 Award, which is a research mentoring grant, which had been present for a long time at the NIH. But we thought that it might be a good idea to go to the Heart, Lung, and Blood Institute and see whether they would agree to partner with us in training some vascular surgeons in this K08 format. And the idea would be to leverage their money, because we would try to get an outside donor of some sort to bankroll our share of this, but we'd double the stipend, because it was so low at that point that no young vascular surgeon could afford to buy groceries on the stipend that would be paid to him for doing some research and basic work in the vascular field. So Jimmy knew somebody there on the staff of the NHLBI, and was able to set up an appointment for us to see Claude L'Enfant, who was the director at that time. So we walked in there, and he gave us a very cold reception. He said, "Well, gentlemen," he said, "I don't know what I could do for you. I don't believe anyone in your field has a grant from this institute." I think he'd looked up my grants, and they were all from the General Medical Sciences Institute. And Jimmy he was now on some private funding in his lab, but he'd totally forgotten to look up Alec Clues.
And at that point, there was a little bit of silence, and I said, "Well, excuse me, Dr. L'Enfant, I think that might be an error. I personally have 4 grants. I have 2 R01s. I'm a member of a program project, and I work with Brad Burke to run a career development institutional training grant, not for faculty, but for residents." And he looked at me, he looked at Jimmy, he looked at John, and he said, "Oh." And then we continued the discussion a bit more, but I think we'd gotten his attention.
So things got a lot warmer after that. And we came away with a deal that if we could come up with the money for our end of this collaborative venture, that he would allow us to sit in on the awarding of the K08s to vascular surgeons, so we could screen them along with the other people in the institute and have some participation in this process, and see if we couldn't develop some vascular surgery K08 awards. So I think that that worked out. The reason it worked out was I went down to see Bill von Liebig, who was ill at that time, and I had no idea whether we were going to get anywhere or not, but I went down to say hello and see what I could do, because I think most of us knew him pretty well by that time, and I'd had a number of personal conversations with him before that. So I went down, and he met with his board, which was just a few factotums that he controlled completely, and they said they couldn't reach a decision about our request, so he dismissed them. He said, "Why don't you stay a while?" And I said, "Sure, Bill, I'm happy to." And what he wanted to talk about was airplanes. He'd been a bomber pilot in World War II, and he had his 25 combat missions over Germany, and he wanted to talk about that. I think he knew I'd done a little flying at the end of the Korean War, so we talked about airplanes for about 40 minutes, never mentioned research, and he then said he'd instruct one of his associates to get in touch with me about how we might work this out. And after a lot of negotiation, Jimmy sat in on and Alex sat in on, we finally got a memorandum of understanding about this. So then we breathed an enormous sigh of relief, because we actually had some money. Before that, we were promising the NIH to go in with them, but we didn't have a red cent to our name to do this with. But we got some money, and by the time we all left the the Lifeline, we had a commitment in writing for $12 million more in funding from them.
Well, the second thing that John did was Fogarty. We are not supposed to call to name that, but you are the one that really
Yeah, well, I
fixed
said,
it.
Tom, you know, vascular surgery has been very good to you. It's payback. And he said, yeah, I guess you're right. No, he gave us $1 million, which was
It's
good.
a matching grant.
Yeah.
Remember, he
Yeah.
gave 1 million first, and then we raised 1 million, he would give
give
another
another.
million.
Yeah.
So that's altogether $3 million.
Yeah.
So.
Yeah.
That's good work,
And
John.
John, there's still one more good work. That is Julie Jacobson.
Oh, yeah, well, Julie, again, had been very well rewarded by our field, and I chatted with him if he wouldn't like to bankroll our conference every year down at the NIH. And he agreed, he and his wife.
The Wiley Traveling Fellowship, supported by W.L. Gore Company, began in 1987 with our immediate past president, Dr. Peter Glovitsky, as its first fellow. 2 other Wiley Fellows have risen to lead the SVS, Dr. Craig Kent and our current president, Dr. Julie Freischlag, the first female leader in SVS history.
Her name was Julie Freischlag, and I had no idea who she was. So off we went to the national meeting. It was about 6 weeks later, and I met her, and I was lucky to recruit her. And she's obviously been a star, and it's really nice. One of the greatest things in academic surgery is to be able to work with outstanding people. It is so nice to people who are trying to do things, that are working hard, that they have a goal and a passion, and I've been blessed with that.
A report by Dr. Bill Pierce on the 20th anniversary of the Lifeline Foundation detailed the positive impact on research of all these fellowships and grants. In 1988, another vascular society was born, the American Venous Forum, with 20 founding members adding to a growing list of regional societies.